It also has another name for it, so that you don't get too confused. It's on page 11 in your book.
Have to be
And it's called
recording.
B-type natriuretic peptide, or BNP. Yes. That's in, well, it's similar. That's in the ventricle. The other one, ANH, is in the atrium. So we have two areas that look for. Now this BNP, they're doing it more and more. We didn't get to have this. We didn't have this many years ago. What this tells us is when the patient is in heart failure, how much heart failure are they in, what is the number, and we want to bring it down. So this is where when the patient's BNP goes way up high, we say, uh-oh, they're holding on to too much fluid. We need to give them extra strength diuretics. So this is one of the tests that we do, and then we've got the ANH, which is the body's natural, and that's found in the atrium. So don't get it confused. What I wanted to say is don't get it confused with BNP. BNP is a lab test, whereas ANH is the hormone itself that is put in to the body or into the bloodstream via the atrium, feeling this stretch of extra fluid. But it doesn't work as well as the test for BNP. Have I confused you? Because I sort of, on that last, disregard that last sentence because I'm looking at it saying, I'm confused now. But I'm not, but I would be. All right. We're going to have to, there's no clock in here, so we're going to have to go by my watch, which says it is 10:30. No, 10:30, right? Fine. Mine does say 10:33 now. Jeez. I was rounding. Okay. So when we're looking, we're asking the patient about those childhood diseases that they may have had. The two particular ones are going to be the scarlet fever and the rheumatic fever. We're going to ask an adult about any pulmonary diseases. I believe in pulmonary, you should have known this word, hopefully. Any problem with the right ventricle? Getting bigger, hypertrophy, right-sided. When the right ventricle is pumping into the pulmonary artery, it's going to the lungs, right? If there's too much resistance in this pulmonary artery due to a lung problem, especially in COPD, it puts more pressure onto the right ventricle along with the left, but the right, for sure, is going to say, well, if I get bigger, then I'll get stronger. And as we know, the right doesn't have as much myocardium, and the right will decide to get bigger and bigger, but become less effective in pushing the blood towards the pulmonary artery. This is where we call this enlargement or hypertrophy as, does anyone know?
Pulmonale.
Cor pulmonale. This is called cor pulmonale. And this is due to the fact that it's not really a heart problem, it was a lung problem in the first place that caused the heart to the right side to enlarge. So, what we look for is pulmonary diseases. Because if we know that the patient has pulmonary diseases, we then start looking for, is there any right-sided failure or right-sided injury or hypertrophy. We look for increased in blood pressures. We look for kidney disease, because we know in kidney disease, if we have glomerulus, proximal distal, if we have kidney disease, this makes the filtering not work well. It also interferes with the effect or the ability of the glomerulus to function correctly. And if we don't have kidney and there is no kidney function, then the juxtaglomerulus here that looks at blood pressure gets off whack and continues to start the renin, angiotensin, aldosterone, ADH system. And we talked about that, didn't we?
Yeah.
And I said, you're constantly going to hear about it, didn't I? And that's another reason why you need to know about kidney failure being part of heart problems. And we also look at CVA. Why do we look at CVA? How did I say a CVA comes from yesterday? Now you're putting it together. Because it's the left ventricle here, or the left atrium, or the right atrium. Either the atrias aren't connecting and sending forth good electrical activity that is picked up, and we have a beat each time. They may be in atrial fib, which means they're just sort of quivering. The SA node is sick, isn't putting out a continuous regular, is sort of quivering there, and every once in a while one of those messages gets picked up by the AV node, then is transmitted. But in that time frame, is everything else working correctly? No, there's going to be pooling. And if there's pooling, especially in these atrias, it's going to go this way and right up and into the brain for a blood clot. And we'll be talking about CVA later on. CVAs most of the time are either blood clot or rupture, bleed. Rupture, bleed are going to be caused by what? Pressure, exactly, blood pressure. They are blood pressure, or rare, they may have a problem with the arteries that they were already born with. Okay. Any questions thus far? Are you putting it together? You're laughing at me. I don't know if I'm getting through or not.
It's just a lot of
It's a lot of information. We're trying to process everything.
I know you are. I told Mr. Hernandez yesterday, I said that you guys had a hard time with me. And he said, well, I told him that it gets harder. And yes, it does. And yes, you have to process all of this now, but does it make sense when I'm talking about it, and when you go and revisit your recordings up here, you're going to see that the story continues, and it's the story that you need to know. It's that story that you tell your children every night, and they memorize it every night, and you think they're doing just wonderful because they seem to be reading when they've just memorized that story because you've gone over it and over it and over it. I'm doing the same thing. All right, objective data. What is objective data?
Which we can measure.
What we see. What we see, not what the patient tells you, which is subjective, but what we see. So when we're looking at this, we know that the blood pressure has been changed. It used to be in the 130s over 80. We considered that normal. It's now down to, we want to see blood pressures 120 over 80. You betcha. That's where we want it to be, or less. So if you have a patient on antihypertensive drugs, then we have a tendency to believe that it is working if you see that their blood pressure starting off up here at 150s is now 140s, 130s, and maybe even 120. Are you still going to give the hypertensive if it's 120 over 80?
Yes.
Yes, why?
Because it has to be, as soon as they will stop, it will increase again.
That's correct. The reason why they have a blood pressure of 120 over 80 or less is because the medicine is working. So you will give it. And I'm giving you a hint because you will get some, what do you do as the nurse for giving and knowing your vital signs as to what does it mean. Do I need to get help now? Is it a surgery patient? If a surgery patient's down to 120, 110, 108, and they're a fairly big person and their pulse is going up, then what do I think? I think maybe hemorrhage at that point. So I have to be aware of what kind of condition am I dealing with as to when is this vital sign imperative to do something about? Or is it because I'm giving a medicine that's making it work? And yes, I need to give it. You will also get questions for Coumadin and heparin for their lab works. Do I give this or do I not give this? And do I hold it? Because you're looking at the lab work to know whether or not you're going to give it. All right, you need to get a normal blood pressure is somewhere between 100 over 60 to 140 over 90. Sometimes the doctors will write on your drugs when to hold a hypertensive drug. That's maybe 100, maybe 90, maybe 110 systolic. If that's the case, then you have to take the blood pressure more or less at that time. Now, if it is low and you're supposed to hold it, do you hold it for the whole day?
No.
What do you think? Common sense. What do you think?
We can check the.
You can recheck that blood pressure. You can recheck that pulse later on. Maybe you hold it at 9 o'clock in the morning, but an hour later, because you held it, you're in there and their pulse is 60 now. You can give it at that point, but make a note about it and check with somebody to make sure it's still in the morning. I wouldn't give it at nighttime if I got the pulse up at that point, but during the morning time, sure. Most patients, do they take their medicines at home at 9 o'clock in the morning every day? I'll tell you no, they don't. Some take it at 6 o'clock, some take it here. There are some medicines that we'll be talking about that need to be taken at the same time every day, or should be taken at the same time every day. That's because they work better and they keep their level there throughout the whole day, and we need to give it because they need to have that level so they have the energy to get through the day. So we'll be talking about that too as we go. You should take blood pressures in both arms. Are you doing that?
Yes, we can. is no dialysis.
Dialysis shunt or graft, I mean,
Or IV?
or IV. Most of the time, there's probably going to be an IV there. I'd still go ahead and take it very quickly. Are you using your ears or are you using machines?
Ears.
Both.
Both?
Yeah.
I hope you're doing both. I don't mind you using those automatic machines, but those automatic machines were supposed to be used temporarily or for patients that you really wanted to keep tabs on. They were not supposed to overrule your ears. And a lot of times they are different than what the true patient's blood pressure is. So if I get a low blood pressure according to the machine, then I better do it by ear before I go notify somebody so that they know I took it both ways. Okay? And I'm sure your instructors have told you to do that. All right. You should do it in both arms because sometimes there is a difference in those arms, and the blood pressure that's the highest in one of the arms needs to be documented. If it's in the right arm, you document the right arm as being the blood pressure because it was the highest. Leg blood pressures. This is important to note that leg blood pressures are higher than arm blood pressures by about 10 millimeters. You already know that?
No.
You should know that. You know it now. Yes? Pardon? Leg. The leg blood pressure is about 10 millimeters higher than the arm. Now, there's going to be a change in that if there's a problem with artery, right? If we have a problem with clotting or artery or whatever, there may be a change in that. And we definitely look at those changes sometimes with our children when they're born with a congenital heart problem. And we look to those leg readings because that tells us that there's a problem, because it won't be higher, it'll be lower. So knowing that it is higher is a good thing to keep in your mind. You do need to know forever how to do posturals. How do we do postural vital signs? We take a blood pressure and a pulse lying down, then sitting up, then standing. Yes, you're supposed to wait so many minutes between, but no one does it. You can chart that it is a positive without the change of 20 being there. In other words, if you started off with a pulse of 80 lying down and a blood pressure of 130/80, you sit them up and it's now 90, but the patient says, I feel really dizzy, I feel nauseated, I feel, and they're diaphoretic. Isn't that a sign of lowering blood pressure?
Yes.
Signs of shock. You can then just lay them down and say that they're positive because they gave you subjective data. And you chart that subjective data, even though there hasn't been a change in the blood pressure and the pulse to 20. A positive, if you go all the way, would be this. There's a change of 20
Okay.
from the start to the finish. Okay? Is that how you were taught? Yes? If you weren't taught that, you're taught it now. And you need to know it because it's on your exit exam and it's on NCLEX. Please do use the correct cuff on NCLEX. They have quite a few nursing, or they've had nursing process of, if it gives you in the scenario that your patient weighs 200 and something pounds. And it mentions in that scenario a blood pressure cuff being whatever size, a medium blood pressure cuff, and you're getting a very high blood pressure with it, you better pick that up throughout that scenario, because the question is probably going to be towards, what do you do now? What is your first priority when you see that blood pressure being elevated? Your first priority is to make sure that I'm taking this with the correct cuff, is going to be your answer. Not do something about the blood pressure, because we know when we use the wrong cuff or wrong size cuff on a patient that we're going to get an obnoxious number, either too high or too low. Okay? And that's what it talks about here in my area of blood pressure. For pulse, most pulses should be taken for 1 minute. I like to get apical pulses, if I can, on most patients. But it's kind of hard to get an apical pulse on a patient that's sitting right there in front of you. It's usually with your patient who's in bed that you can get that. You can develop a way to be able to get breaths along with pulse, so you're not sitting there for a great amount of time listening. I used to be able to do both at one time, and sometimes you had to do it with infants, because that's about as long as you could get, was to just get it all at one time, because they don't give you another chance, because they're screaming and crying then. You need to know where to listen. That is on adult health test NLN, it's on your exit exam, it is on NCLEX. It may not be on NCLEX anymore because it is a specific answer. Now they're giving more critical thinking answers. So it is midclavicular, 5th intercostal space. You need to know that forever. And it says here, listen at midclavicular, 5th intercostal space. Yes, you need to know that. You need to document if it's regular or irregular. You should also document listening and feeling the pulse at the same time, and if there is a discrepancy between that. Every time you hear a lub-dub, you should feel a pulse at the same time. If it is irregular, you may hear irregular here at the heart, and you may not feel a pulse for each one of those lub-dubs that you're listening to. That is where you're going to document that it's irregular. If there is a pulse deficit, how do you get a pulse deficit?
Two nurses measuring, the one doing the apical, one doing the...
Okay, the radial.
Radial.
Right. And if you come up different, what is your next nursing intervention? Trick question. Huh?
We can
Do it again. All right? Your answer for most questions that have to deal with, you do it and you don't get something correct, you do it again. If you know that that temperature is 95 and this isn't an old person, then you better retake it and really position it good into the ear, because you know in a child that is abnormal. Okay? All right. They ask questions about that. You need to know it forever. Why am I spending a lot of time on vital signs? Because you need to know it. We sort of skip over a little bit of it and just teach you how to do it. But in theory, you need to know the theory part for NCLEX. A thready pulse. This is a pulse that disappears when you're feeling. It is usually a very rapid pulse. It could be in a patient who is losing their blood pressure or in shock. It can be due to a reason that they may have a cardiac dysrhythmia that is so rapid you can't feel it. And we have to do something about it because rapid pulses are not compatible with life, just like slow pulses are not compatible with life, or not very long. The patient can be in it, but sooner or later it's going to cause damage, and the patient is going to decompensate in front of you. Sclerotic vessel. A sclerotic vessel. Has anyone felt a sclerotic vessel? The vessel, usually you can feel a pulse, but when you feel the vessel or the vein up here, it's like it's really tough, and like it doesn't give and it doesn't move and it just stays right there. That is not a good vein. That if you have to, it may be nice and bulging and it looks good, but when you feel it for an IV, it's not going to be a good vein because it's sclerotic. It's not really, it has very little room to accommodate a catheter in there, and it will probably infiltrate anyway. So, do you need to know the numbers with it? Oh, well, you didn't get the back part of this, so let me go over it. What's respiratory orthopnea? You're going to have to take notes on this one, because I didn't know I had it on the back.
The person's having a hard time breathing while laying down. Is that
Correct. Oh, it did come out?
Yeah.
It's there?
Yeah.
Very good. All right. Respiratory orthopnea. Orthopnea is difficulty lying flat for breathing. How do you ascertain this is concept?
Dangle, when you wake the patient up from the bed, dangle his leg.
That would be for vasovagal. Orthopnea is when they are lying down, they have shortness of breath or dyspnea.
Fowler position.
Correct. What we find out, but their beds at home don't do Fowlers, do they?
No.
So you ask them to determine whether or not they have orthopnea. How many pillows do you sleep on at night? Do you have to sleep on your recliner chair at night? Those are ways to find out ahead of time in your history, do we have orthopnea? What happens when you take the pillows away? I get short of breath. Now, this is different from another definition or vocabulary word that you need to know, and that vocabulary word is paroxysmal, nocturnal, dyspnea. Paroxysmal, nocturnal, dyspnea. Paroxysmal means comes and goes, whenever. It can happen at any time. It doesn't happen regularly, but it could happen right now, and it may not happen for a month from now. So paroxysmal means anytime. Nocturnal meaning nighttime. Dyspnea meaning at nighttime, on occasion, I wake up and I have dyspnea, shortness of breath. What that is that makes it different than orthopnea is the fact that it happens at nighttime, and it is associated with homeostasis. In other words, when we are laying down flat sleeping, all that blood that pooled in our legs from sitting in class all day today, that dependent edema that you got of your ankles because it was hot out and you put that fluid into your third space, now has been reabsorbed back into your blood volume, and increases that blood volume back to the heart. The heart usually is unable to accommodate that amount of fluid. And if there is heart problems, what will occur is there will be a backup of that fluid into the lungs, causing a type of pulmonary edema. So the patient wakes up gasping for air during the nighttime due to the fact that there's been an increase in blood flow back to the heart that the heart couldn't keep up with, and it backflowed back to the lungs. Does that make sense? Yes, there is a difference. Please know the difference. It's on the test. Paroxysmal, nocturnal, dyspnea. It is not orthopnea. There will be questions out there throughout this cardio that you will have to determine, was this paroxysmal or was this orthopnea? Okay? All right. Can we continue on till about 11:30, or are you hungry? Keep going. All right. Inspection. Is clubbing an early sign or a late sign, and what is clubbing? It's a late sign. And why do we have clubbing? What is clubbing?
It's a form of edema.
It's what?
Edema, buildup of fluid.
It's not a form of edema. Lack of oxygen.
Yes, COPD.
What are those signs and symptoms of long-term lack of oxygen? That's COPD. That's not long-term O2. What is, since you said that, what is barrel chest? Where does that come from?
Not getting enough oxygen, right, in your body? Or
Pretty much your muscles become.
Muscle is working hard to.
No, okay. Barrel chest. What happens in COPD?
You can't breathe.
Can't breathe.
So
All
you
right,
can't
fine.
compensate.
That's a good medical term.
You're trying to compensate for it, so you.
What happens
Try
in,
hard to.
what happens to the alveoli here? And all, or the bronchioles?
It shrinks.
it's not able to exchange gas properly.
Okay, we're unable to exchange
shrinks.
gas properly. What happens in emphysema? Because most of the
Scar
time we
tissue
see
on
barrel
top of it.
chest in
Scar
emphysema,
tissue.
not in asthma.
You holding on to the carbon dioxide, more carbon dioxide?
Okay,
And
why?
scar tissue.
You got that there. Yeah, we're holding on to carbon dioxide. But why? What's happened here?
Scarring on the tissue.
I don't know the term, but
Loss of
they-
antiquity.
No, they rupture. That would be-
They can rupture, and then you get a pneumothorax.
Loss of
What
antiquity.
happens is the smooth muscles, the alveoli that have these areas, remember they have these like a grape,
Scarring. Scar.
they deteriorate, they get destroyed. So we don't have
Lose aesthetic,
them.
right?
And you lose elasticity, I heard that.
Yeah.
Elasticity. And what happens is they either collapse or the airways collapse into each other, leaving this, like this, full of CO2, but many alveoli having CO2 or air trapped. So the air trapped in the alveoli, trapped because there's constriction or there's no ability, it's been destroyed by smoking or whatever other irritants you have, a lot of these alveoli then build up and cause the lung to inflate because it's trapped all of this air. And so when we have the capillaries going by, is there any oxygen in there to pick up? No, it's only CO2. So we just pick up CO2. That's why their CO2 levels are sky high. They don't have, because they're trapping. And as this inflates the lung from being this size to this size, the diaphragm grows and accommodates that. And that's why we get barrel chest.
Wow.
We get barrel chest because we have so much trapping of air, is that it's spreading the diaphragm to accommodate the overinflated lungs. Yay? Now you know. There is a difference, isn't there?
Yeah, till now I know that it's working hard.
It's a long term.
Yeah.
A long term. As you can see, we have to destroy quite a few alveoli here to get the lungs to inflate, to cause the barrel chest. That's why when I'm asking here, getting away from barrel chest, I just got off onto that because you had a misunderstanding about it. It's a long term. Many of your questions are going to ask you, nursing priority. Does that mean that it's right now? Yes. Is the question asking that? Or is it a long-term nursing intervention to take care of this? And that's where you're going to have to use your critical thinking from what I talk about in my stories to which one is this question asking me about. Now, I was off onto O2. O2, long term. What do we see? We see clubbing of the nails. That means that instead of the nail going down and then coming up and over, if you had those acrylics, you'd have that little down. Your nail just goes this way. That's clubbing. Did you know that? You lose this dentation of, because around your cuticle, you lose that indentation because of lack of oxygen. It can't keep the cells alive anymore. So you're laughing. Why?
That's a lot of information.
It's like we're learning this over again.
I'm trying to process it.
You gotta know the why behind. So you lose that and you get clubbing. What else do we see in long-term oxygen deprived or ischemia?
Sinus.
You might see cyanosis. That takes a while to get cyanosis, but that's going to be before clubbing, okay? Huh?
Shortness of breath.
Pale skin?
Capillary.
No. Okay, what is capillary refill? I hear that. Yeah, I know. It's the blanching. What's it tell you? Why are you doing the blanching? It's circulation. It has nothing to do with oxygen. You always want to put down there, most times, students want to say, oxygen. But can I blanch that and say, oh, that's 100%? Oh, that's 50%. Can I? No. So blanching is circulation, strictly circulation. And that's why we put seconds onto it. Less than 3 seconds means I've got good circulation. If it takes forever to go back to pink, something's impeding my blood circulation. Now I need to go find out why. No, we're going to see decreased hair on the legs. Wow, you didn't know that, did you?
No.
How many of your patients out there that have oxygen problems don't have hair on their legs? Start looking.
Is it strictly for
Bill might think it's a good thing.
Look at the circulation and picks up the oxygen. So the only way you can get an oxygen level is with a pulse ox, not by looking at it. All right. There's decreased hair on the legs. Legs become flaky.
Lack of lotion.
Huh?
Lack of lotion.
Lack of look. Oh. What do the toenails do? They get hard, built up, ugly. You don't even want to get near those nails because they're uglier than. These are long-term signs and symptoms of somebody not getting enough oxygen. And then, of course, our biggest one is LOC right at the very beginning, and or pain in the extremities. Those are early signs. These are later signs. These are long-term. And you're going to find this, the reason why I'm going over it, because we're going to go over Berger's disease and we're going to go over Raynaud's disease. And all of these have to do with arterial problems and long-term. And you're going to see these signs and symptoms being for your Berger's disease. Why? Because it's long-term oxygen. It's Berger's, not that other word. Okay? It's not boogers. It's burgers. And it's not the burger that you eat. All right. Clubbing. It occurs from O2 deficiency, congenital heart, smoking. Yes, yes, yes. Oh, reddish brown extremities. Yes, reddish brown. Those ugly reddish brown ulcerated. If they're ulcerated, is that arterial or is that venous?
Venous.
It's mostly venous. Could be arterial, but usually it's venous. So reddish brown legs. If we're looking, and early on, if we see jugular vein distension, in other words, when they're laying down, you may see jugular vein distension because we're in homeostasis. Everything's equalized out, everything's pumping, we may see it. That's not considered jugular vein distension. You just see the blood in the vessels. But when you put them up into a Fowler's or another high Fowler's, what we should see is everything drop out. We shouldn't see anything here, and you don't see anything on your persons or your co-students next to you because we don't have any jugular vein. But if we have right-sided heart failure, right-sided heart failure, and it can't pump this way because it's failing, so it's back up and it's backing up into the superior vena cava, the jugular vein is right there. So when we put them up, you see this balloon out and it becomes very big. And you go like this against it and it fills up, which means it's not draining into the right atrium. Jugular vein distension is one of the signs and symptoms that you cannot forget that goes along with right-sided heart failure. Peripheral edema, right-sided heart failure. In here, that capillary refill, guess what? I have a note about it. It only tells us blood flow, nothing else. You need to have a machine to take the pulse ox. Palpation, edema. Edema is sort of a late sign. It is a third spacing. It can be due to a burn. It can be due to dependent edema, sitting, having your ankles swell because of that. Not good vessel return going back up. If we have venous stasis, then we have pooling of blood, and now we're into the problem of clotting. So edema can be one of the signs and symptoms of right-sided heart failure also. If the right side can't pump to the lung, then it's going to back up. The least resistance is going to be not be able to take all the blood that's coming into the right atrium. That's going to build up into the inferior vena cava and superior vena cava, so jugular vein. We may see some ascites, some liver problems. You need to know those by heart because there are many questions on exit exam and on NCLEX that refer to heart failure. Is it right-sided or left-sided? The component, the one and only component that makes it left-sided heart failure is lung. Either they have difficulty breathing, shortness of breath, increased respiratory rate, or they have crackles or wheezes. Once you get that component, it is an emergency situation because they can die from left-sided heart failure, not from right. They die from pulmonary edema. And you got pulmonary edema in respiratory, didn't you? Okay, well, we'll be going into it even further, and you'll just love it because I'll give you just so much more information. Yay! I hear you. Okay. You need to palpate for edema. You need to know if it's 1, 2, 3, 4 past. If it doesn't come back pretty quickly and it just sort of pits there for a while, not a good sign. Okay? We need to let somebody know. So, what can we do for edema of the extremities? Walking, maybe. Elevate. Yes, you know that. Above the heart. Elevate above the heart. What else?
Rest.
Yes, compression stockings, TED hose. If we're going to rest, we better be careful because that edema is pushing down on arteries and
While
veins
resting, you have
and
to
causing
elevate.
clotting. All right, you got to be careful.
Yeah.
So-
While resting, you have to elevate the leg
Yes. Yes.
level to
Above the heart.
the upper. Okay.
We'll talk about when it needs to be level. That's when they have a artery disease along with a venous disease. You can't put them up because of artery. You can't put them down because of venous. So you put them out straight. Okay. You need to know Hohmann sign. Everyone knows Hohmann sign?
Yes.
You need to know it forever because there's questions about it on Adult Health NLN.
Calf. And pain in the calf.
Okay, how do you get pain in the calf? What do you have to do?
Clotting.
No. What's the test? What is Hohmann sign? Explain it to me. You're doing it, but you have to explain it.
It's a
Dorsiflex, I hear. That's the
Yeah,
word.
yeah.
Dorsiflex of the, did you say that too?
Yeah.
Sorry, I didn't hear it. But good.
Yeah.
See, you know something. Dorsiflex of the foot towards the head. And you feel pain in the calf or behind the knee. That is your answer that you are looking for at all times. Dorsiflexion of the foot towards the head. They could say dorsiflex or flex. but it's the wrong way. They will try, it's there, it's not really to trick, but you need to make sure that the whole answer is correct. The whole answer, not just part of it, or it's wrong. Auscultation. This is where we hear murmurs. Murmurs, you need to know the definition of a murmur. It is a turbulent blood flow. It is a prolonged sound caused by the narrowing of the valve. It makes a swishing sound. Lub dub sh, lub dub sh, lub sh dub, lub sh dub. You sometimes listen for murmurs. That can also be a murmur other than the heart is usually that swishing sound will denote possible, it's called a bruit, B-R-U-I-T. They sometimes listen here to the carotids because if we're thinking there's atherosclerosis, which is decreasing the amount of blood being able to get to the brain, we're looking for that in the carotids, and they may have to have that repaired, surgically removed. Pericardial friction rub. What was one of the reasons for that?
Prevent the heart to
Damage to the heart.
Some kind of damage to the heart, such as myocardial infarction is usually one of them. It can also be due to, before we had the bags for driving of the steering wheel, we used to get a lot of injuries coming in with the seat belt or hitting the steering wheel. That would injure the pericardium. The pericardium would then get inflamed. It sounds like sandpaper being rubbed together. The best way to hear a pericardial friction rub is to go left of the sternum at around the 5th rib and have them leaning forward, because they're going to be leaning forward anyway because it takes the pressure off. So, to hear the rub, have the patient sit and lean forward. It allows the rub to be heard clearly. Put your stethoscope left of the sternum. That's 2 questions that I just answered for you. All right?
Thank you.
How do they sit? How do you hear? And where do you put the stethoscope? It can occur after an MI. That's a 3rd question right there. So it's all in my notes. If you know my notes backwards and forward, and I've talked about it, it is on the test. All right, you can go to lunch. Be back at 12:30, 12:35, something like that. I'm sure you're just enjoying yourselves here.
Are we gonna come back in here?
Yes.
Which one? Yours?